In part one, I talked to you about some host factors that are associated with different rates of adverse events: age, gender, prior doses of vaccine, prior infection with a vaccine agent. Other host factors include skin color, where it's harder to detect the rash that may be caused by some vaccines in darker skinned individuals. Pre-existing hypersensitivity to a vaccine component can predispose to hypersensitivity reactions. Underlying immune deficiency, especially with live viral vaccines, may predispose to some serious adverse events. And genetics, which we're just beginning to study the genetics of adverse events associated with vaccines. In the next 10 years, I'm sure we'll see many more studies identifying specific genetic predisposition to adverse events. For immediate hypersensitivity reactions, we're referring to hives or urticaria, angioedema, and anaphylaxis. Hives are depicted in the top figure, and angioedema, or swelling, usually in the face, in the lower picture. These adverse events are usually mediated through IgE antibody, and there are a number of allergens in vaccines that can trigger allergic reactions, such as residual media left over from growing the vaccine agent, stabilizer like gelatin used in measles and mumps, rubella, varicella, and other vaccines to help keep the virus stable over time. Trace amounts of antibiotics, not the antibiotics that we usually give for therapeutic purposes, and preservatives have all been associated with allergic reactions to vaccines. I always ask the question, why doesn't everybody develop IgE antibody in response to these vaccines that could predispose to allergic reactions to subsequent doses? I've had more than 20 doses of influenza vaccine, and I still don't develop an allergic reaction, but other people develop it after the first or second dose. We'll understand that more sometime in the future. We studied reported allergic reactions associated with the 2009 H1N1 pandemic vaccine in the United States and observed an interesting pattern by gender. This slide shows the reported cases of documented hypersensitivity reactions by age, and we don't have the accurate denominator data by age. We do have accurate denominator data overall, and actually slightly more males than females were immunized. But we observed an interesting pattern of higher rates of reporting of adverse events in women of childbearing age than in boys and men. In the pre-adolescent age group, the ratio of female to male reporting is 1 or up to 2 in the older children. But then for women in the childbearing years, there are 4 to 9 reports in females as compared to males. This decreases again with older age. We don't understand the pathogenesis of why there are higher rates in females. We also see some delayed onset hypersensitivity reactions, such as the limb swelling that occurs 2 to 3 days after the 4th or 5th dose of acellular pertussis containing vaccines, such as seen as this boy on the left with swelling of his right thigh, and then a CT scan on the right showing that the swelling's not just in the muscle but also in the subcutaneous tissue all around the leg. Specific pathogenic mechanisms haven't been identified. There are some immunologic differences suggested from a couple of studies. We also see similar large local reactions associated with other vaccines, such as influenza vaccine in this 8-year-old boy who's son of one of our staff at my institution. And these are problematic, but they usually resolve and are not associated with any long-term effects. We see true delayed hypersensitivity reactions, such as erythema multiforme, after smallpox vaccine, well documented here in studies by Vince Fulginetti. I've seen this twice now after varicella vaccines. The big question that many people ask is, can vaccines cause autoimmune diseases? Well, the answer is yes for a couple of autoimmune disorders. Smallpox vaccine was associated with myopericarditis, primarily in studies in our military population with the clustering of cases in the second week after vaccination. precise mechanism not clear, but associated with at least 2 different smallpox vaccines. Probably true for all of them. Guillain-Barré syndrome was associated with the 1976 pandemic influenza vaccine with highest increased risk in the second and third week after vaccination, but clearly in the 6 weeks and maybe up to 8 weeks after vaccination, there was an increased risk, as depicted here in studies done in multiple states in the United States. The mechanism involved is not clear. There are several different mechanisms for Guillain-Barré syndrome. This is an autoimmune disorder. It's not just antibody, but also cell-mediated immunity involved in disrupting the function of peripheral nerves. Fortunately, for the vast majority of individuals, it's reversible. The attributable risk of Guillain-Barré syndrome following influenza vaccine in 1976-77 was about 10 per million cases. Many years, there was no evidence of any increased risk. 92 to 94, there's about 1 per million increased risk. And with the pandemic vaccine now, with several different studies done in different populations, there is an increased risk of about 1.6 per million overall. It's age-related. I'm not showing the data here. We also see a small drop in the platelet count in children who receive measles-containing vaccines, as shown in these studies where serial platelet counts were done by day after immunization by Oski and Naiman, and that nadir is down at around 4 to 5 days after vaccination. These are individual children with multiple platelet counts being done who were in the hospital for other reasons. We think that this initial decrease is due to a direct effect of the measles virus attaching to platelets. They then get taken out of circulation. In a small number of individuals, there's a later immune thrombocytopenia, about 1 in 30,000 in different countries, Europe and the US. This has been best studied. This is an autoimmune disorder. We have seen enhancement of the target disease associated with some experimental vaccines. In the 1960s, formaldehyde inactivated respiratory syncytial virus vaccine was developed. It induced neutralizing antibody, and it looked like it was going to be protective. But among the children who received this vaccine, they had enhanced rates of pneumonia around 9 months later when they developed wild-type infections. The vaccine didn't provide lasting protection, but did lead to an enhancement of the disease that they were trying to protect against. Same thing happened with measles vaccine and inactivated measles vaccine, formaldehyde inactivated vaccine, where atypical patterns of measles occurred more than 2 years after the vaccine and out to 20 years after the vaccines were given. The pathogenesis of this enhanced disease was that it was poor quality antibody, low avidity. The protection waned with time, even though there was initially evidence of protection, both it decreased over time. And the children who had been immunized didn't develop a good T-cell immunity associated with these vaccines. And then when they got infected, the virus would be circulating in the blood and antibodies would attach to them. They get immune complex mediated disease, causing the enhancement, especially of pulmonary disease. We've had 4 different rotavirus vaccines developed. The initial one, the rhesus rotavirus vaccine, was called RotaShield, abbreviated as RRV. This has been taken off the market because of a serious adverse event that it caused into susception. And we now have 3 different vaccines on the market, which are highly successful and protecting against disease. The RotaShield was clearly documented to cause intussusception or infolding of usually the small bowel and the large bowel, but it could also have been within just the small bowel. And that can disrupt the blood supply and can lead to the need for surgery if it can't be reduced with air or barium enemas. The pathogenesis is not clearly defined. We believe it's probably edema or swelling of the bowel wall and or development of lymphoid nodules, which can provide a leading edge for the bowel to invert upon itself. The rates of intussusception with the rhesus rotoshield were about 10 to 20 per 100,000. The rates associated with the two vaccines that have been most studied, around 1 to 2 per 100,000, tenfold lower rates, which is fortunate, and this is tolerable. We can deal with that. With BCG vaccine, small percentage of children develop swollen lymph nodes, as shown on the left side, and sometimes these progress and break down and cause draining ulcers, such as shown on the right side. There are both host and immune and vaccine factors that are associated with the rates of these. The differences by the vaccine strain that's used, the technique of administration, and the age of the children. The rates of abscess or lymphadenopathy are much higher in children under 1 than they are for individuals 1 to 20, at least a 10 to 15-fold higher rate in the younger children. Disseminated BCG, or musculoskeletal lesions, also occur at higher rates in children under 1 than in individuals 1 to 20 years of age. So age-related adverse events. Disseminated BCG occurs at a rate of about 1 per million. Individuals with an underlying immune deficiency disorder called interferon gamma receptor deficiency are at particular increased risk, and also HIV-infected children are at about a 1,000-fold increased risk. Yellow fever vaccine is administered to individuals who live or travel to the endemic areas in South America and in Africa, as depicted in yellow in this slide. There's an increased rate of an encephalitis if yellow fever vaccine is given to young infants. If you're 9 months of age or older, there's a rate of about 1 per million, but when it was given to infants under 4 months of age, it was 400 to 5,000 per million, about a 1,000-fold increased rate. So we don't give this vaccine to children under 9 months of age. We also see a unique disorder that mimics yellow fever, wild-type yellow fever. It's called yellow fever vaccine-associated viscerotropic disease. The rate is less than 1 per million. The case fatality rate is more than 50%. The risk factors identified to date include age over 60, individuals who have underlying thymus disorders, some who've had their thymus removed or irradiated, are at increased risk. It's probably a defect in the innate immune system that occurs in others that hasn't yet been identified, that may be very unique just for this yellow fever vaccine virus. This is where genetics and genetic studies could help us identify those individuals beforehand, so we don't give vaccine to people who are predisposed. We see delayed onset of some severe adverse events. With measles vaccine, very rarely children develop an inclusion body, children have developed pneumonia if they've got an underlying cell-mediated immune deficiency disorder, such as leukemia or severe HIV infection, AIDS. Also, inclusion body encephalitis occurs 5 to 6 months after vaccination, a progressive infection in the central nervous system. We don't understand what the underlying host defect is here. Again, it would be very helpful to understand that. There are only a half a dozen such cases that have been reported. Oral polio vaccine, used widely throughout the world, is associated with rare cases of vaccine-associated paralytic poliomyelitis, abbreviated as VAP, occurs at a rate of about 1 case per 750,000 first doses. Now, since children get multiple doses, you will see other rates, and it's much lower when you count all of the doses that are administered. This disorder occurs in both the vaccine recipient and those children can transmit the vaccine virus to their contacts and who sometimes have become paralyzed from the vaccine. Globally, WHO estimates there are 250 to 500 such cases that occur every year with OPV. Risk factors are age over 18 and being susceptible to one of the strains of polio, underlying B-cell immune deficiency disorders, or multiple injections, that same provocation polio that occurs with children who have wild-type polio in their blood can occur with the vaccine, and we've seen it with children who got multiple injections. In the United States, the cases of vaccine-associated polio are depicted in the red bars, 6 to 8 cases a year, until we switched over to a sequential IPV-OPV schedule, and then finally just switching over to IPV altogether, and then, of course, no further cases. And we're in the process of this transition taking place throughout the world. We also see circulating vaccine-derived polio outbreaks. The vaccine-derived polioviruses for just a little over a 1-year period are depicted here on this slide with outbreaks that have occurred throughout the world. It's not worth going into details. These have diminished considerably in recent years, but that's a continuing problem and leading to the changeover to all IPV vaccine. Smallpox vaccine, another live attenuated agent, causes some significant local infections and reactions. Was the vaccine that led to successful eradication of smallpox, which caused much more severe disease. When this vaccine was given to pregnant women, it can cause an infection in the fetus, gets across and causes disease. Interestingly, we don't give live attenuated vaccines to pregnant women because of this concern, but it's really smallpox is the only one where we've documented any clinical illness that's been associated with this. And fortunately, Vince Fulginetti told me that this infant survived and the lesions healed and did quite well. With smallpox, we also see significant local adverse events in children who have underlying eczema because they have an underlying T-cell immune deficiency that, particularly for this virus, makes them more susceptible to these kinds of skin lesions and problems. And if you're severely immunocompromised associated with HIV infection, as this military recruit was, you can get a disseminated vaccinia infection. This recruit did recover with therapy. In more recent times, we've identified problems in infants who had an unrecognized severe combined immune deficiency disorder at the time they received rotavirus vaccine. But then the vaccine virus can continue to multiply and cause a persistent diarrhea and growth failure. The only therapy is a bone marrow transplant. The point I would make is that many of these adverse events are preventable by following the recommendations, and we withhold the vaccines from children who have true contraindications from vaccines. But we all need to work toward letting the public know that we make vaccines as safe as possible. That's necessary if we're going to continue to get high rates of participation in immunization programs by members of the public. Thank you very much. This ends the part 2 of our lecture.